So good afternoon, everybody, and a happy new year to you all. Uh, as per the discussions with Dr. Doke sir, and are proposing to start the clinical research unit activities on every Friday afternoon from today, that is January 1st. So, in this inaugural lecture, and I invite all the faculty of Central Research Unit on behalf of Dr. Doke sir to participate in this endeavor of Bharati Vidyapeeth to, to study research methodology, critical appraisal of medical literature, how to write a paper, how to read a paper, and many more things in the new year that's we're going to have. Right. So I propose to do this talk. I'll briefly discuss about the introduction of critical appraisal, and then we'll talk about evidence-based medicine, what are its core components, and we'll concentrate on methodology issues and what we need to learn to interpret the results, and also we'll try and learn some tools of critical appraisal. And in the earlier part we have dealt up to this, and we didn't do the critical appraisal of diagnostic studies, therapy studies, and etiology studies, which we will be doing right this time. And so let's go and start the see what happens is there is a lot of medical literature that is getting accumulated, and so somebody is waiting. Yes, admit all. Okay. There are 3,000 plus new papers per day that are coming out, and 1,000 new Medline articles are added every day. And there are about 46 randomized clinical trials that are being reported every month. The number of biomedical journals are doubling since 1980. And in our clinical environment, there are always 5 knowledge needs for every inpatient encounter, and approximately 2 knowledge needs for every 3 outpatient encounters where we need to update ourselves for the management. So, what is critical appraisal? So, as you have seen, medical literature is the most explosive field of journal publications worldwide, and 45 new medical articles are appearing roughly at a rate of at least one every 20 seconds, 26 seconds. And if a physician was to read every medical journal published, they would need to read 5,000 articles per day, which is humanly impossible. So why not take the results of studies on their face value and apply all the findings in clinical practice? Can we translate the evidence from the literature into our own clinical environments? You ask yourself this question after going through this lecture. Firstly, there will be conflicting conclusions drawn from different studies. Secondly, the real life medicine rarely follows the restricted environments in which clinical trials take place. So, whatever may be seen in the clinical trials may not be practically possible to observe. So, why this happens? One hand, we say that fat is bad for you. On other hand, there is literature saying it may cause stroke, increase the stroke risk. One hand, salt raises blood pressure. On the other hand, cutting salt won't lower the blood pressure, some studies say. On one hand, cholesterol is bad, and if there is too much of cholesterol lowering, then there may be stroke. On the other hand, certain cholesterol is good. On one hand, so many conflicting things will. So why we require critical appraisal skills are, so there is a daily need for valid information for diagnosis, prognosis, therapy, and prevention. Inadequacy of traditional sources of information is always felt because the textbooks become out of date very fast. Because for a textbook to come into vogue, there will be almost 3 to 4 years that will be there. And frequently, the experts get outdated also, and they are giving wrong information. And the didactic CMEs are usually no, they are ineffective, and there is overwhelming medical journals that are present. So there is a disparity that is happening between our diagnostic skills and clinical judgment, which increase with experience. We don't have to read anything, we have to see more number of patients, and with our knowledge these skills will increase, but the up to date knowledge and clinical performance based on recent developments always decline. Our inability to afford more than a few seconds for finding and assimilating the evidence is also very glaring. We will not be able to spend much time. So, critical appraisal assesses the validity of the research and statistical techniques that are used in studies and generate clinically useful information from them. So, when we have critical appraisal skills, that's what happens. We will distill out useful information from the literature, and we'll come to know what type of literature we should study, and we can classify them. What are the articles which we are studying? So it answers basically two major questions. When you have this skill, it assesses whether the article has internal validity. That means the study design and methodology are sound, foolproof, and so it tests the efficacy of the article. The second one that happens is, does this research has external validity? Can we extrapolate the results or generalizable the results? And that is called effectiveness. So any article has got two things that are happening here. One is efficacy, the other one is effectiveness of the study. Critical appraisal allows doctors to assess the research results and allows them to decide which research will have a clinically significant impact on their patients. It excludes the research that is poorly designed. That is a basic essence. Right. So what is then the second aspect which I said we'll talk is evidence-based medicine, the term which is very frequently used by many people without knowing what it is. The conscientious, explicit, and judicious use of current best evidence in making clinical decisions about the care of individual patients. And see, these are got three aspects which we are going to see, and proposed by David Sackett, 1996. Evidence-based healthcare requires the integration of the best available research, and we have to decide what is the best available research evidence with our clinical expertise and the patient's unique values and circumstances, what they want. I also have to take into consideration. So, evidence-based medicine is a new philosophy of clinical practice and a process of lifelong learning. For this to practice, you require critical appraisal skills. It emphasizes systematic and rigorous assessment of evidence that is generated in medical literature for use in decision making in healthcare. For example, if you have to decide whether a stroke to be treated with thrombolytic therapy or mechanical thrombectomy, we should have some support from the literature. So as you see, this is the experience with any condition with stroke management. For example, see what happens is the background knowledge requirement is goes down as the age advances, because we are gaining more skills in diagnosing, but the knowledge needs are increasing in the, ever increasing. Now what happens is we are not able to spend time to know the what are the latest trends. Then in that case we have to utilize whatever time is at our disposal to the best of no, best possible results. So evidence-based information cycle consists, you have to get the evidence. That means you read the article. Now why do you do this? Whenever we go to rounds in ICU or acute medical ward or some other wards, then you develop a question, a query about that, and you ask that question, and you acquire enough information from literature. Then you have to appraise. For example, whether CT angiography is enough to decide about the operability for carotid endarterectomy in sufferers is a problem which you have to read and come to a conclusion, then apply the evidence that you have read, and you see the outcome. This is the evidence based thing, what we are calling. So you formulate a question. Here it is a clinical question. In research methodology also there is a research question. Both are almost same. You search for the best evidence with which to answer the question. So you'll have to know what are the sites where which you can search, like PubMed, like Trip database, and like Up to Date, and so many other things are there. Critical appraisal: whenever you come across the suitable article, then you evaluate the evidence that is found and grade the evidence and apply the results to the clinical practice. So this is the evidence based medicine cycle with which and implement and then analyze the results. So this is the introductory part of what we are going to do. These are three aspects of evidence based medicine: research evidence, whether it is class 1, class 2, class 3, and what is the strength of recommendation. So this is research evidence. And then the clinical expertise: how many years this person is working in that field and he gains enough knowledge. So it's not only a research evidence, it is also clinical expertise. So don't go on fighting that, though this article in this it is mentioned like this, so why are you not practicing? But this gentleman had enough practice, enough seen, and also he considers patients' preferences. Some people may say that I don't want to take the treatment which is very costly. Don't rub it on them ki this is the only treatment. You have to explain to them what is the effect size of the intervention you are planning, etc. So in that context, evidence based medicine has grown since 96, and I'll tell you, in those formative years, many number of articles were subjected to evidence based medicine criteria. See, where is the meat in clinical journals? The top 20 journals contributing to ACP Journal Club were analyzed: New England Journal of Medicine, JAMA, Lancet, Annals of Internal Medicine. The abstracts of these articles between 94 and 98 were subjected to validity criteria of based on evidence-based medicine. So out of 147 articles, only 12 articles we can extrapolate onto the patient care, or they have passed the test of EBM. Like that, you see JAMA 7.2, Annals of Internal Medicine 7.6. So you see what our prestige journals also not bringing out the required healthcare articles which we can extrapolate onto the patient. That's why it is important for us to know about critical appraisal. So now let us see, if we start reading an article, what to look in a study: the journal, the organization of the article, the clinical question, the study design, observational or experimental studies, hierarchy of evidence that is generated in the results, and the research pathway to understand some of these key, whether there is anything more to be done and what type of studies where in the research pathway the present study. So Dr. Gauri Oka is participating in various journal clubs, and she is sensitizing the students in a beautiful way. I have attended one of the classes. This will supplement what she is teaching. So you look in the study and you see what is happening in the study. Are we looking at a group, or is there an intervention to some or all of the participant or study subjects? Is there a control group, or is there random selection? If there is no control group, it is observational study. If there is a control group, it becomes observational analytical study, and it can be cohort study, case control study, and cross-sectional study. If there is random selection, randomized control trial. If there is no random selection, non-randomized control trial. So this particular thing is important for all therapeutic intervention for clinicians. So this is a type of studies which we come across in medical literature. So let's see. So what the methodology, it is general practice. What happens is in any journal club, the interested or for clinicians who are doing the literature studies, they just look at the abstract and briefly concentrate on the aim and go to the conclusion. But what we are supposed to know is we're supposed to know all these things. What is population sample, what is bias, what are the confounding factors in the study, whether blinding is done, street analysis, whether reliability of diagnostic states, validity, and what are the outcomes that are studied. So these various things are to be given importance in, so when in our journal clubs and your article studies. So the type of clinical question determines the type of study that will be appropriate. So whatever clinical, so we'll see some examples. A study will answer the question by stating an hypothesis and tries to either prove or disprove that hypothesis. So this is a basic essence, and only one well-defined hypothesis to be done for each study. Some studies generate hypothesis, that is case reports and qualitative studies, but in any real randomized control trial, there should be only one well-defined hypothesis. It is a human tendency to study, to hope to study many things in the time that is given to us, but that will not get us anywhere. So whenever you make a study protocol or when you are reading an article, you see how many hypotheses were there. If it is only one well-defined hypothesis on which the sample size is calculated, you better read the article in great detail. So in that also we look at the patient or the problem and intervention. That means the main intervention, exposure, test or prognostic factor under consideration, and comparisons are there, a comparative intervention, and what is the outcome, what to achieve, measure or effect. All these aspects in any study you will have to consider, and we'll see what is the importance of outcomes and other aspects. So the different types of clinical questions, I mean, what is the medical literature offering us and what type of studies we are encountering in our medical literature? They are diagnostic studies and they are basically case control studies. Then you have some good evidence generated there. If there are only case series, there is no quality evidence that is generated. Etiology studies, it's RCT, and case control study or cohort study. So if a study which is dealing with etiology, if any of these designs are used, then you can say that it's a very good study. For the therapy study, RCT and number of RCTs are clubbed to make a meta-analysis, or number of intervention studies can be clubbed under systematic review or meta-analysis, and a probable effect size can be drawn and decided. So prognosis, again cohort study and longitudinal survey. So these are the designs that are required to generate a quality of evidence for these four types of studies which we come across in medical literature. So you see, for anything you study you identify the population that is studied, the stroke population of ischemic stroke, for example. Then you see target population, anterior circulation in acute ischemic stroke population you can target. Then you can see eligible patients of stroke severity scales, and then you study the participants by some intervention. Then you get some results, and that results you have to extrapolate into the again target population. So that will go to the target population. And some more thing happened when we do target population, we say that some are excluded, some are based on our exclusion and inclusion criteria. Then only the results will be applicable to the target. And this is the usual the cycle of population and samples and how we derive in any study. The research pathway which you should understand is any biological target is not identified. Now the coronavirus antigen, the capsule antigen, and the new drug idea to deal with that, and the discovery of new compound. But initially it is tested in the laboratory models, then animal testing, then human testing goes through phase 1, phase 2, and this is safety and feasibility safety and feasibility trials, and maximum tolerated dose will be established in phase 2. And this is the where randomized controlled trials will come. These are the effective, this is the effect of the intervention is studied, and after it is approved by concerned authorities, the drug is unleashed into the market, and it is how it is faring in the real life situation is studied in phase 4. So these are the phase 1, 2, 3 and phase studies. So, but whenever any study is conducted, no study is foolproof, and there are errors in studies. These errors will cause misleading results, wrong conclusions, and sometimes interventions may appear more promising, or on the other hand, they may be less beneficial, and sometimes they may be by chance or due to faulty designs. These errors can come. Now, what are these errors? Bias and confounding. There are two things. Bias is an error that you should be aware of in any article you study. It is not due to chance. It cannot be measured by statistical methods because it is introduced by the design, by the researcher. Bias introduces an error at any stage of the study. Good research technique only avoids bias. So whenever bias is there in the study, it cannot be corrected by any statistical technique. So what are types? You can have the bias right from the literature, search bias and foreign language, because you may not include papers, and these topics will be taken up one after other in the coming classes. And running the trial and performance bias, collecting data, interviewer bias, recall bias, Hawthorne effect, and analyzing the results, attrition bias, when you have a lot of patients that are lost to follow up. So the other error that can come is a confounder, which is different from bias and is not created by some mistake, and hence it is not controlled by research technique. It can be controlled by statistical method. Confounding arises from an already existing real life relationship. We can say the example of coffee drinking and cancer, cigarette smoking and cancer. The confounders can be neutralized by statistical methods, not like bias, or eliminated or can be spread equally between various arms of study. Randomization removes the baseline confounders, as the known and unknown confounding factors have an equal chance of entering the control group or treatment group. So, two errors we studied: bias and confounding. The confounding, exposure and outcome. This is, say, coffee drinking or cigarette smoking and carcinoma lung, and there may be a confounder that could be either of them. It has got more coffee drinkers will smoke, and so it also can cause the lung cancer. So a confounder has a triangular relationship between exposure and the outcome, and it is not on the causal pathway, but it affects the outcome. So there are methods to reduce confounding, and whether the study article in the design has shown restriction, matching, or randomization. In the analysis stage, whether there is stratified analysis, multivariate statistics, etc. So that you have to judge in critically appraising an article. So let us see what happens in a particular study in a graphic fashion. There is a target population, and once the target population, okay, I'm sorry. So matching, and that is the method, or restriction. The sample is selected, randomized, and what happens then after randomization? And we have to conceal allocation. That means the randomized things should not be revealed to the person who is doing the research. An envelope may be, take an example, whatever intervention A or B is written, and it is sealed and kept. So when randomization number comes, the envelope is open, and whatever is inside is given to the patient, and after that what happens, the treatment arm is implemented, trial starts, and there's blinding of doctors, and patient also doesn't know what's given to him, and blind doctors and patients, and so we don't know what's happening, and what medicine they have got. The trial ends, and then the blinding is unfolded, and then the outcome also is blinded. The individual who is doing the outcome assessment, say modified Rankin scale in stroke survivors, after a particular medicine is given, is not knowing what type of medicine is given. That is a blind assessment, and there may be some dropouts which may affect the results. And finally, so you have to concentrate on the placebo arm, and when was the concealed allocation and the trial arm. So now why we are studying all this is, in any trial, you in any paper, you will have to give importance to all these aspects that are discussed here. Okay, so it's in a brief about that. Before we go on to the next, diagnostic tests, reliability and validity. What is reliability and what is valid in a diagnostic test arena? Also, some papers deal with the diagnostic tests, whether RT-PCR test or antigen test is good for COVID-19 virus detection. So this is in that context only we should study the reliability and validity and sensitize yourselves. Reliability is the consistency of the test results on repeat measurements. So more number of times you repeat the test, it has to yield the same result. So there are types which we will discuss in forthcoming classes: test, retest reliability, inter-rater reliability, intra-rater reliability, alternative form of reliability, split half reliability. So these are various types of reliabilities the faculty should know. And validity refers to what extent a test measures what it is supposed to measure. And it is also very important, because if a test is supposed to measure the nerve conduction velocity properly, is it measuring or not measuring? When you do EMG, are you getting the correct result, or the needle is faulty or something like that? So it is all types of criteria validity, phase validity, content validity, construct validity, incremental validity. All these things will be dealt in subsequent classes and in our lifelong learning process. So these two things are particularly important for understanding it, right? So what finally in the article, what is the endpoint? Is it a clinical endpoint like mortality, disability, disease progression, improvement of symptoms or quality of life, or is it a surrogate endpoint like the reduction of cholesterol, reduction of blood pressure? That means we don't know whether it is going to translate into clinical outcome or not. For clinicians, clinical endpoint is important. So whenever we select in our journal clubs, we have to know our health needs, our patient needs. So it is best to select based on clinical endpoints as far as clinical studies are concerned. So this is the part one, and now we'll go on to the second point, the results. The skill in the critical appraisal is to understand what data will be generated by the methodology. So in any paper they are doing study, they are observing target population, they have drawn a sample, and they are doing tests or interventions are done, and what to check what data they are generating. So you should know what are the types of data for a critical appraisal skills, and you have to check the correct statistical method has been applied to the data or not. You have to see, and also to verify that the results are correctly described using the analysis. That means there is a misconception on most of the minds that you should know a lot of statistics to understand a medical literature. That is wrong. Statistics is not the science of doctors. You are only supposed to know what is the data that is generated in a particular research activity or a particular journal article, what type of data is given, and what are the statistical tests are used. How to do the test is not our knowledge. We should have enough knowledge and about what is the type of data, and for that type of data what type of statistical tests are to be used. So data type is categorical data, and quantitative data. And categorical, you have nominal unordered data, which can be binary or multi-category, or ordinal data, ordered, mild, moderate, severe. In quantitative data, there is discrete counts and continuous or measures. So we'll see in the next table. The categorical data is nominal unordered. You have binary or multiple, so that means male and female type. In if you are generating that type of data, or married, divorced, single, engaged, nominal, multi-category data. In ordered data or original data, you have grade of cancer, mild, stage 1, stage 2, stage 3, etc. In other data, that is numerical data, this is the categorical data and this is numerical data. In this, you have discrete counts, number of children studying, number of children present, absent, etc. The other one is continuous data, measured age, body weight, blood pressure, temperature, etc. So, what type of data is dealt in the article? You should be able to identify that data. Then why it is important is that the data dictates what type of tests are to be used. Paired data and unpaired data. Now we understand what is a paired data. Paired data means you start doing a intervention at one place. You give a type of drug to a particular individual and see their cognitive function at this level, and you follow them up, and again same group of people are tested again with the same tests. So this is a paid data. Unpaid means you have done it only once. So categorical unpaid data, you use McNemar's test. The categorical data, which is paired data, large sample chi-square test, small sample Fisher's exact test. So these names you come across in medical literature kit, but the way to understand is where they are applied, and that's very important for us to know. Similarly, if you have to see continuous data, whether the data is normally distributed or not normally distributed, that makes a lot of difference in our understanding. If it is a normally distributed data, means you have a bell shaped curve that is there, all the things are equally distributed on either side, so that is the normally distributed. This normal distribution can be easily understood by the present day statistical softwares. You put the data and it will tell you whether it is normally distributed or not. If it is normally distributed, then you use parametric tests, statistics. That is, if it is a one sample, it is a one sample t test, two samples unpaid t test, two samples paid to t test, two samples unpaid ANOVA. So there are multiple. If it is not normally distributed, you use non-parametric tests, non-parametric statistical tests. So you have a parametric, you have a non-parametric statistic, Wilcoxon signed rank test. If it is one sample, if there are two unpaid samples, Mann Whitney U test. If two samples are paid, you Wilcoxon rank sum test, or Kruskal Wallis, ANOVA, and Friedman. More than two samples, you do this. So these tests, which will bother us very much when we study articles, if we know where they are applied and what type of data they are studying, whether the data is normally distributed or not, can be assessed. When we do standard deviation, I'll also tell you how to judge data is normally distributed or not normally distributed. Okay, so now next. Again, I have tabulated this only that so that you can easily remember it. This table is given categorical data, right? One sample chi-square test, Fisher's exact test if it is a small sample. If it is non-parametric data, Wilcoxon signed rank test. If it is parametric data, one sample t-test. That means the importance is your data should be either normal or non-normal. That will dictate parametric test or non-parametric. Comparing two groups, chi-square test, McNemar test, and non Mann Whitney rank sum test and paid t test. Comparing more than two groups, it's always ANOVA in non-parametric, Kruskal Wallis ANOVA unpaid, and Friedman in the paid, and ANOVA in the paid or unpaid ones. So just to familiarize yourself with various types of tests and not getting so much bothered about these tests, how they have come. We should know what type of data we are generating or we are studying and what tests they are used. After that, there are certain things which every clinician should understand. These are the tools of critical appraisal, and means in all medical literature you will come across standard deviation, confidence interval, p-value, relative risk, risk ratio, odds ratio, relative risk reduction, absolute risk reduction, numbers needed to treat. All these various things the clinician should know. These are to be learnt by the clinicians and use them. So standard deviation is used for data which are normally distributed. I said already that this is a normally distributed graph which you can draw and indicates how much a set of values is spread around the average. That is, one standard deviation means 68% of the data are lying on either side of the central line. Two standard deviations includes 95% of the data. Three standard deviations includes 99.7% of the data. Now, if a mean is there, and along with the mean, your standard deviation is also given, and uh, mean and standard deviation, when they are mentioned, if the standard deviation into 2 exceeds the mean, the data is not normally distributed. Simple formula: if mean and standard deviations are given, if the standard deviation into 2 exceeds the mean, the data is not normally distributed, and the tests that are employed should be non-parametric tests than parametric tests. Next we'll see p-value. What a p-value is used indicates how likely the hypothesis is true. So that is the essence of p-value. The probability value is used, which is indicates how likely hypothesis is true. So when we start doing a study, we always say the null hypothesis. There is no difference between two treatments. When you start giving, say, rivaroxaban to prevent and warfarin, we say there is no difference between these two drugs. If there is a difference, we'll try and identify it and say whether that difference has become because of chance or not. So the probability of the difference having happened by chance is 0.5 or 1 or 50 is to 50, 0.5 in 1 or 50 is to 50, that is p is equal to 0.5. If it is 0.05, it means 1 in 20 times, that is 0.05 in 1. If it is 0.01, it is 1 in 100, highly significant. So 1 in 20 is significant and 1 in 100 is highly significant. That means the difference which we said is not there. If you see a difference and that difference having happened by chance is 1 in 100 is highly significant and 1 in 1000 very highly significant, that is 0.001. That is what is p-value for you, and this much all the faculty and everybody should know. Confidence intervals are used to indicate a range that is likely to contain the true population value, not the mean value of the sample, because from the population you have taken the target population and sample and they have studied that and you have extrapolated the results to target population. Now this is not the same thing that's happening, but there is a truth in the population. That truth should be as close to the result as you have obtained. That's what is a confidence interval is saying. Confidence says where the universal truth lies, and that is calculated based on the truth which you have calculated from a sample. 95% confidence interval means we can be 95% confident that the true effect is within that range, and it should not include 0 or 1, when then the value becomes insignificant. So it is 0.5, 0.5 to 0.6 is okay, but minus 0.5 to 10 is not significant, so it should not cause. Now that finishes confidence interval. So we studied standard deviation, p-value, and confidence interval. Now we'll see what is relative risk, which we wanted to learn. Risk is the probability that an event will happen. And what is the probability? It is usually used in cohort studies. The number of events divided by number of people at risk. Like example, one boy is born for every two births. So the probability of giving birth to a boy is 1 by 2. That is 0.5. Because you should know this, because you are going to compare it with the odds. Second example, 1 in every 100 patients suffer from a side effect from a treatment. Then the risk is 1 by 100. So it is 0.01. So 1 by 1, 1 by 100, and 1 by. So this particular thing, again we'll explain in the next slide. What is the risk ratio? So we have some relative risk. Now it is a relative risk ratio is calculated by dividing the risk in the treated group by the risk in the control group. If risk ratio is 1, there is no difference between the two groups. If risk ratio is more than 1, then the rate of the event is increased compared to controls. The risk ratios are given with confidence intervals. If confidence interval for risk ratio does not include 1, it is significant. So for every intervention, this type of table construction you should know. Contingency table, and it has got a bundle of information in this table. And the disease status or outcome is on this axis, that is a column, and exposure to risk, exposure to treatment, intervention, or test result. If it is positive here, that is A. It is the exposure to treatment is positive, but the result is negative, it is B, and the total is A plus B. And exposure to risk or treatment is negative, not treated, and the disease is present but disease is absent, C plus D. So with various combinations, you can control event rate can be calculated by C plus D, and experimental event rate by A plus B, and absolute risk reduction, control event rate minus absolute risk reduction. Relative risk reduction also can be calculated by experimental event rate by control event. Will give you enough information, and you can always cross check what they are saying is correct or not correct. Oh, now we'll go to the odds. Odds is a way of comparing patients who already have a certain condition with patients who do not have. They are the controls. It's usually used in case control study. Odds are calculated by dividing the number of times an event happens by the number of times it does not happen. Odds ratio is also calculated by dividing the odds of having been exposed to a risk factor by the odds in the control group. So we'll see the example. One boy is born for every two births. So the odds of giving birth to a boy are 1:1. So they are 50:1, or 1 by 1, that is 1. As compared to risk, we have taken the same example there also. One boy is born for every two births. So the probability of giving birth to a boy is 1 by 2, that is 0.05. So now you see, when the sample size is small, odds and risks are different. Now we'll see the second example. 1 in every 100 patients suffer a side effect from a treatment. So the odds are 1:99. That is 0.01. But risk, 1 in every 100 patients suffer from a side effect. Similarly, if you calculate the risk, 1 by 100 is also 0.01. So the essence is, if the sample size is large, odds and risks are same value. But if the sample size is small, then they have got different values. Again, you have odds of outcome in exposure group A by B, odds of outcome in non-exposure group C by D, and you have to calculate the op a by a into d by c into b is the odds ratio, which is usually calculated, and we have to cross check. Odds ratios are also given along with confidence intervals. So that's we have now dealt with so many beautiful things, risks, and again I'll summarize. One boy is born for every two births. That is cohort studies. 1 by 2, 0.5. One odds. If you want to calculate odds, case control studies 1 is to 1. That is 1. They are different. But if you say 1 in 100 suffers from a side effect for a drug, that risk is 0.01. Odds means 1 in 100 suffers from a side effect. The odds are also 0.01. So the essence is risks and odds are same if the sample size is large, and they are different if the large sample size is small. So this is the odds ratio. One means there is no difference in risk between the groups. Odds in each group are the same. So in papers they mention what is the odds ratio. If it is more than one, the rate of the event is increased in patients who have been exposed to the risk factor. If it is less than one, the risk factor is reduced. If it is given with 95% confidence intervals, and if it does not include one, no difference in odds, it is significant. So relative risk reduction, these are used to know how often a treatment works rather than just whether it works. How often is more important. That's why absolute risk reduction is to be learnt in this context. It is the difference between the event rate in the intervention group and in the control group. That means how many strokes are prevented by mechanical thrombectomy versus no thrombectomy. And if it is displayed in relative risk reduction than absolute risk reduction, it implies that it is a proportion by which the intervention reduces the event rate. Numbers needed to treat is the number of patients who need to be treated for one to get better. So results of placebo controlled trial of oral antifungal agent in 100 men, 100 women after 3 days of therapy is given here. Given antifungal, improvement is seen in 80, no improvement is seen in 20. Given placebo, improvement is seen in 60, no improvement is seen in 40. Now, how these results are, you can, the experimental event rate minus control event rate is 20%. That is absolute risk reduction. Numbers needed to treat, the absolute 100 by absolute risk reduction is 5. That means if you treat 5 people, one will show improvement with the drug. Relative risk reduction, if you want to show, as the medical reps usually do, the incidence of candidiasis is reduced from 40% with placebo to 20% with treatment, that is by 50%. They say there is 50% reduction with this drug, please use it. But you know that it is only absolute risk reduction is 20% if you are able to critically appraise what these MRs are saying to you. So results of placebo-controlled trial of clevastatin in about 1,000 women and the results after 5 years of treatment. You see, this is very interesting thing here. Patients are given clevastatin. They studied about 5 years and they have followed up for results of whether they are survived because of myocardial infarction or died. You see, 998 people have survived, 2 died when it is given clevastatin. But placebo, 996 have survived, 4 have died. So how these people will tell us? If absolute risk reduction is shown, it is only 0.2%, and if you calculate numbers needed to treat, it is 500. But these two figures are not publicized to us. What they show is the incidence of ischemic heart disease is reduced from 0.4% with placebo to 0.2% with treatment, that is 50% relative risk reduction. It is the same impressive figure, and that's why we get attracted to use clevastatin. If we don't critically appraise medical literature, this is what's going to happen. Now that is a therapy part. Now there are indicators for diagnostic tests which are called sensitivity, specificity and predictive value. These are used to analyze the value of screening or of the tests. Think of any screening test for a disease. For each patient, the disease itself may be present or absent, and the result may be positive or negative. So sensitivity and specificity we have to learn. They are used to analyze the value of screening tests or lab tests. Sensitivity means how often the test is positive in disease. S and out will learn what it is. Specificity in healthy patient, how often the test is negative. Negative in health, SP in. So these are the two terms which you remember and I'll explain to them. The sensitivity is how often the test is positive in disease is calculated by A plus C. In a healthy patient, how often the test is negative is calculated by D plus B. So a highly sensitive test will help in ruling out the disease. A highly specific test will help in ruling in the disease, SP in. How is it? Then example is HIV test. An ELISA test is ordered for all the patients and they undergo HIV test, ELISA, and they say ELISA negative. Then we are not bothered at all. That is highly sensitive. So the highly sensitive test is used to rule out the disease. But if HIV ELISA is positive, what do? We'll ask for Western blot test. So that means there are some false positives in that, but unless we do Western blot test, we are not saying that he doesn't have the HIV test. That is the importance of knowing sensitivity and specificity. And you also have positive predictive value calculation A by A plus B. If a test is positive, what is the likelihood that the patient will have the condition? If the test is a negative, what is the likelihood that the patient will be healthy? This is D by D plus C. So this contingency table analysis is very important and you can calculate this by these figures like 20, this is a blood test result for a gastric cancer. It is present positive in 20, absent in 30. But overall disease is absent but test is positive. Here is disease is absent and false negative, but disease is present, sorry, but test is negative, and here both are negative. So based on the formulas which I have shown you, you can calculate the sensitivity, specificity, predictive value. Not only that, you can see pre-test probability, post-test probability. I'm not going to the details, but this is how it is to be done. So diagnostic tests, you got a target population, you got a cases, non-cases. You have to compare the results with gold standard test and new diagnostic test result. All people have been tested and compared with the new diagnostic test with the gold standard test. Was there an independent and blind comparison with a gold standard or diagnostic test? So these important points are part of the critical appraisal. So in the coming classes, when we do separately diagnostic test critical appraisal, I will try and give you a proforma which is only specific diagnostic test. So we'll have performance separate for therapy paper, diagnosis paper, prognosis paper, which are different critical appraisal forms. Where Dr. Gauri is teaching you a critical appraisal proforma, which is flashing on this. Please learn that. Then next step, we'll segregate into various categories of studies: sensitivity, specificity, positive predictive value, negative predictive value, likelihood ratios, pre-test probability and odds, post-test probability and odds. We have to calculate based on the results which we get in the contingency table. And then you see applicability of these studies. Are your patients similar to the target population? Is it possible to integrate this test into your clinical settings and procedures? Will the result of this test affect your management of the patient? Is it affordable? So these are some of the things which you can calculate, which we have already told you about this, and these are the formulas that we use for diagnostic tests, which we will elaborate when we do. Now second is the treatment studies, which we have already said how to calculate the absolute risk reduction, relative risk reduction, whether there is concealment there, whether blind comparisons are made, and what is the dropout, which I have already told you. And so various parameters which are to be measured. Was there a clearly focused clinical question, which I have already mentioned? Was the randomization procedure explained? Was concealed allocation used in the allocation of interventions? Whether blinding was used effectively? Was the follow-up complete? Was the intention to treat analysis made? So these are some of the important aspects in a therapy paper which we'll learn in future. So this is a sensitization class, and upon the results, control event rate we will calculate, experimental event rate, absolute risk reduction, relative risk reduction, NNT, and confidence limits. All these things can be verified by various knowledge, the tools which we acquire, which we study. And in this also, are your patients similar to the target population? Were all the relevant outcomes considered? Will the intervention help your patient, or the benefits of the intervention worth the risks and costs, and have the patient's values and preferences considered? A GBS patient, if comes and we say that, oh, you take IVIG, which is 5 lakhs, and because we don't explain to him what is the benefit of this treatment and how far it is useful, is it 100%, is it 50%, is it 30%? We have to give him the choice to make whether to take the treatment or not. But obviously, because we ourselves don't have that much knowledge, we don't say, we only know that IVA is used in GBS, so let us prescribe it. But the DM students and MD students, they have to go a step beyond this. They have to study the effect size and explain to the patients. Similarly, etiological studies are also and analyzed, and I'm not going to the details of this. And finally, whenever you go on to the rounds, you develop a clinical query, and you make a educational prescription, and you write the patient's name, the disorder which you are seeing, and what is the intervention given, outcome given, what is the question that you have come across in the rounds, and you note down there, and you try and search the results and validity of this evidence, and then you can always make a CAT file. So what I say is, EBM has swept the world in less than 25 years. The appearance of EBM does mark a radical break from the old world system of management. It's a new world in which the traditional authority and skills of doctors are questioned. There are many ways in which it will help develop, and information on its own doesn't change the practice, but we must learn more about how we move from evidence to change. But we know it's hard to learn the tools of critical appraisal, but we have to learn. And when a steamroller comes through, you are either part of the roller or part of the road. That's what a brand said. So finally, before saying that this is educational prescription, and with the critically appraised topic or CAT files, which is a structured one-page summary for all the clinical queries we get in the rounds, begins with a declarative title, a clinical bottom line, a clinical question that starts the process, and you study about that particular clinical question and make a CAT. This is I'll show you a CAT. What is a CAT? This is clinical bottom line, CAT of multiple sclerosis, interferon delays progression. In our rounds, we have a question: in patients with secondary progressive MS, does interferon delay the progression of the disability? That means, will it delay going on to the bedridden state? So we don't know really, but we know that it is being used. How long it will take the patient to go on to the bed? Then you do the search and come to a conclusion and see the evidence. Progression of disability, 95% confidence intervals calculated. Time to outcome is 33 months. The control event rate without drug, with interferon, experimental event rate. This is the relative risk reduction. The numbers needed to meet 9, and wheelchair bound 13. So now you have an idea that 1 in 9 patients will become bed bound in 33 months time. That's how the patients will understand better. That's why you have to learn these techniques. And this is the hierarchy of evidence with which the evidence-based medicine helps you in deciding what type of intervention you have to give. In vitro research, animal research, case reports, case series, case controls, cohort studies, randomized controls, double-blind studies, and systematic reviews and meta-analysis. So if you have evidence by meta-analysis, that is the topmost evidence which you can blindly apply to the patient. So with this, I think most of the things which I wanted to sensitize people on this New Year's Day, I have done. And good luck to all of you, and happy learning. And it's a lifelong learning process. We, with Dr. Doke's directions, will continue doing various types of critical appraisals of various types of papers, be diagnostic, prognostic, etiology, therapy papers. Then we'll try and tell you how to write a paper. Then also we'll try and do a couple of journal clubs where how to critically appraise an article will be discussed. An article will be circulated well in advance so that people can critically appraise it. Then we can discuss it out. So exciting things we can plan if all of you are interested in continuing this lifelong process. And I think if there are any questions or anything which we can have a couple of times, can we discuss, sir? Okay, sir.
Certainly, we can discuss, sir.
Anybody has any question, you can ask. Otherwise, sir, you make some comments about our program. Sir, you wind up the class by your comments.
Okay. Dear colleagues, it was really interesting. Dr. Gurti has volunteered that we should start it, and he was the first person who said that from a clinical perspective, the student and faculty should know how this published article should be critically reviewed. And the main objective of critically reviewing is that one should not get carried forward by the presentation. We ourselves should be able to draw the conclusion based upon scientific knowledge. And he has tried to explain you, and in fact, it was so comprehensive. It explained and it touched etiological studies, clinical trials, diagnostic tests. Therefore, I say that it was really comprehensive. In fact, in future, we may have a small pieces also in depth now for a pathology person, how you can actually develop the test or carry out appraisal of tests which are developed by others. Something this type, maybe this was really comprehensive, but we can break up small pieces also and discuss it thoroughly. Right, sir? And this will
That
be
will be in future.
continuing every week. Every week we'll be having some discussion on selected topics, and you will come to know before 2 or 3 days we'll circulate it.
Thank you, sir. I think we'll break it down into small components. It is only sensitization class.
Yeah,
I
I
only
understand. Yes.
yes, we'll do it, sir. Right then, if there are no questions, I wish you all of you a very happy New Year. Thank you, sir. Then shall we close it?
Yes, sir, sure.
Right. Thank you.